Hi, I'm Dr. Famida Jiwa. I'm the President and CEO of Osteoporosis Canada. We're honored to have with us tonight our guest speaker, Dr. Marla Shapiro. During this hour, you will hear about bone health, you will hear about osteoporosis, and you will hear about the impact of osteoporosis on your health and on broken bones. It is my great pleasure to introduce Dr. Marla Shapiro. Since 2000, Dr. Shapiro has been the health and medical expert for Canada AM. In addition to her weekly appearances on Canada AM, Dr. Shapiro is also seen regularly on CTV News Channel and as the medical consultant on CTV National News. In 2003, she began hosting Balance, Television for Living Well. She also hosted Dr. Marla and Friends. Dr. Shapiro has written a regular column for the Globe and Mail, as well as a health column for Canadian Health and Living magazine. She currently writes her weekly blog on the ctv.ca website. Please join me in welcoming Dr. Marla Shapiro.
Thank you so much. I couldn't agree with you more that what is the most important thing for us is really empowerment through education and really understanding what bone health is about, what a fracture can mean to you. And tonight we're hoping to go through why bone matters. And so many of us don't talk about bones, so many of us don't recognize it. This is really the silent disease. So we're going to go through a whole bunch of material. We're going to turn you into bone scientists. We're going to make you experts. And you are going to continue the message of education. So thank you so much for joining us tonight. This is what we'd like to review tonight in our overview. We'd like to look at bone structure and osteoporosis. We need to understand what our bones look like so we can understand what osteoporosis is. There are guidelines from Osteoporosis Canada. We'd like to go over what those are and a wonderful service called the Fracture Liaison Service. And we're going to tell you what that's all about because that's another empowering organization for you. What the faces of osteoporosis look like. You might be very surprised when you see those faces. They're not the bias that most people have of an older individual, an older woman. It actually can be across many genders as well as ages. We're going to look at treatment options. We're going to look at tips for healthy bones, and ultimately we'd like to take some of your questions. So let's first look at bone structure and osteoporosis and what I mean by that. Most people don't recognize that bone is actually a living tissue. And that means that it's constantly being broken down and then it's being rebuilt. And that process of turnover between bone that we want to remove and bone that we want to rebuild is called a process of remodeling. The loss of living bone tissue, however, is what makes bones fragile. And that means that it can lead to the likelihood of a fracture. So it's the fragility of a bone that's really important to assess. Now, this slide may look complicated, but this is what we call our bone remodeling cycle. And this is what's going to turn you into bone specialists so you can understand what's happening in your bone as we speak together. We have two very types of basic cells, one called the osteoblasts. And I often remind my students when we're talking about bones to think about that letter B in osteoblast because it means those are the bone builder cells. They are the cells that are building the foundation of your bones. Then there's something called osteoclasts. I think of the C in osteoclast as cleaning up, and that means that they resorb areas of the bone so that new bone can be built. Think of building a house, for example. You want to excavate the foundation so you can build a really strong foundation for your home. The osteoclasts would be the resorption or the diggers that build the foundation, and the osteoblasts would be the cells that lay down the bricks in the mortar, so to speak. And that cycle of osteoblasts and osteoclasts, resorption and building, mineralization, the laying down of calcium is part of the activation cycle that gives us our strong, healthy bones. So I'm going to ask you to remember these two cells, the osteoblasts, the bone builders, the osteoclasts that do the resorption, because we're going to come back to what happens to them when they get out of phase. So we think of osteoporosis as a silent disease. Why do we say that? Well, often because it doesn't give you any symptoms at all. Let's break down that word, osteo. Osteo is simply the Latin name for bone. And porosis, think of the word porous or porosity. It means that it's full of holes. And when you put the two together, osteoporosis, it means literally bones that are full of holes. And that's something that we don't want to happen. So what are the early warning signs? Well, if I were to ask you and you scratch your head and can't come up with one, will you be right? Because the answer is none. Most of the time, we can develop osteoporosis without any symptoms whatsoever. There's something called a fragility fracture. We're going to talk about that more specifically, but after age 40, if you've had a fracture, that's concerning. Loss of height. When you see your doctor, when we take your children, we always do weights and heights, but through adolescence and adulthood, we should continue to be measuring height. Height's really important. It's a parameter that you can keep track of. Most people know what their height is, and I'm often surprised when people tell me that they think that they're shrinking. And I'll often ask them, how much height do you think that you've lost? And if you think that you've lost 5 centimeters or 2 inches or so, that's very alarming. But if I, in my office, am measuring you regularly and I see that you've lost half that amount, 2.5 centimeters, when I measure you, that too is a warning sign that makes me think that there's a problem. And that broken bone or a fracture, that can be an early sign of the disease, and as well, stooped posture. Often a posture is stooped because the bones are fragile and it's leaning to that particular direction. So these are some of the early warning signs. Now let's look at what osteoporosis looks like. So on the one side, you see a woman at 52 years of age. She's before her menopause. That's called premenopausal, and that's what a healthy bone looks like. You can see how strong the bone is. Those porosity areas that you see, those are normal porosity. But look at the other side, a woman at 68 years of age who's now well into her menopause, and with the loss of estrogen and other factors, you can see how much thinner the bones are now, how much bigger those pores are, and that truly is osteoporosis, a bone that is porotic, a bone that has lots of holes. It looks distinctly different than our healthy premenopausal woman at age 52. The difference between the two. Okay, so this is a relatively common condition. In fact, fracture is one of the most common consequences of osteoporosis, and the sad detail here, the sad fact, is that many people are not diagnosed with osteoporosis until after a fracture occurs. And we really do want to prevent that first fracture. Did you know that at least 1 in 3 women and 1 in 5 men often forget that they too can be at risk, will suffer from an osteoporotic fracture during their lifetime? Think about that number. 1 in 3 women, 1 in 5 men. And over 80% of all fractures in people over the age of 50 are actually caused by osteoporosis. Many people will relate it to a slip and fall, and that's the reason they broke their bone, but in fact they broke the bone because the bone is fragile, and that's the reason that it breaks. In Canada, there are approximately 30,000 hip fractures that happen, and more Canadians suffer fractures affecting the spine, the wrist, the shoulder, and the pelvis, and when you add up these numbers, they're quite impressive. So what are the key risk factors for fracture that you need to know about? Well, firstly, there's age. As we get older, we do see more of a risk. We do see more of a preponderance in females compared to males, 1 in 3 versus 1 in 5, but that doesn't mean men are off the hook. Low bone mineral density. We're going to talk about what this test means more specifically. That fragility fracture after age 40. For women who have an earlier menopause than the average age of menopause, which is usually early to mid-50s, so let's say 45 or so, that can be a risk factor. And certain medications can put you at risk. One well-known medication is a cortisone or prednisone called glucocorticoid. And if you're on that therapy for more than 3 months because of a different condition, that can put your bones at risk. Look at your weight now and compare it to the weight at age 25. If you are 10% lighter than you were at age 25, that too is a risk factor. And parents, both a mother or a father who had a hip fracture, that tells you something about the genetics of your bone, and that's considered a risk factor for you. And if you have a past history of falls, not necessarily falling and fracturing, but even just falling, because we know that the tendency to fall is a significant risk factor for fracture. So these are some of the questions that you can ask yourself and tick off, where do I fit in some of these key risk factors that might put me at risk for fracture? A fragility fracture, what does that mean? Well, the most common sites where we see a fragility fracture are typically at the wrist, in your spinal column, your hip, and your shoulder. And it means that a bone break will occur typically either spontaneously or following a minor trauma, so you cough or you sneeze. But what most people don't recognize, if you fall from a standing height and fracture after age 40, that's considered a fragility fracture. It's not normal to fracture even if you fall. I have many patients who will fall on the ice in the winter and break a bone and say, well, you too would have broken a bone because it was so icy and I fell so hard. But the answer is no. After age 40, with a slip and fall, if you break a bone, we consider that a fragility fracture, and we consider that a risk factor for future fracture. What are the consequences? Well, it significantly can impact your quality of life. So that means, for example, disfigurement. But one of the most important things that I think about when I think about my older patients is the independence in living life, the independence of activities of daily living. So for example, think about breaking a wrist. What does that mean? Well, it can be very difficult to get yourself dressed. It can be difficult to brush your teeth. It can be difficult to do any self-grooming. So that loss of mobility, the loss of independence, and that ultimately can lower your own self-esteem if you feel that you can't do self-care. And here we're not even thinking about what happens if you're the primary caregiver and this happens to you. What about all the other people who are impacted by your disability? So here's a question. I want you to think about this for a moment. And you're going to answer this to yourself because I can't hear you, but which of the following is the most common in people who are over 50 years of age in Canada? So let's think about what our choices can be. Heart attack. Well, we know that heart stroke's the leading cause of death in our Canadian population, but is it the most common thing that happens to people over the age of 50? What about breast cancer? What about stroke? Or what about osteoporotic fractures? Think for a moment about what your answer might be. Well, in fact, it is osteoporotic fractures. Many people think it's heart attack. A lot of women think it's breast cancer. But in fact, it's osteoporotic fracture, and we really underestimate the prevalence and the incidence, that means new cases, and what this can mean to you as an individual. So let's look at the numbers here. This is the annual incidence of common diseases. Look at the osteoporotic fractures compared to heart attack, or compared to stroke, or compared to breast cancer. In fact, fractures from osteoporosis are more common than heart attack, stroke, and breast cancer, all combined. And that's not to underestimate the importance of all these other diseases, but it just punctuates the fact that we really do underestimate and undervalue the fact that the annual incidence of common diseases, osteoporosis, unfortunately, is our number one, but we don't necessarily give it our number one attention. Now, what's the burden of fractures on the healthcare system? I think this is very important for us to think about the cost of our healthcare, because with our aging demographic, our aging population, if we don't stem the tide of fractures, what it will mean to our healthcare system, what it will mean to our healthcare dollars. Well, the yearly cost of the Canadian healthcare system for treating osteoporosis as of 2010, and now we're 4 years later, so those numbers have increased, was about $2.3 billion or more. And fewer than 20% of fracture patients in Canada actually undergo diagnosis or adequate treatment for osteoporosis. In other words, their fracture gets treated, but we don't necessarily ask the question, why did the fracture happen? Is this patient osteoporotic? Should we be intervening not only with management and strategies for treatment of the fracture, but think about what the underlying cause is? What is the underlying disease? Let's look at hip fractures. Well, osteoporosis, in fact, is responsible for about 70 to 90% of the 30,000 hip fractures that we see annually. 23% of women, 37% of men who suffer a hip fracture will die within the following year. Now, while hip fractures are more common in women, the likelihood of dying, in fact, is more common in a man if he has a hip fracture. And each hip fracture in Canada costs more than $21,000 in just the first year after hospitalization, and about $44,000 or more if the patient ends up, unfortunately, having to be institutionalized. And hip fractures, think about this fact, consume more hospital bed days than stroke, diabetes, or heart attack. So if you have a hip fracture from the time that you were admitted till you have your surgery, till you're mobile and independent again, think about all those days. So what are the consequences of underdiagnosing and undertreating osteoporosis? So for example, in a woman with a hip fracture, well, a hip fracture, typically 40% of these women have had a prior fracture. They've had a very important event that has gone undiagnosed, untreated, and 40% of them go on to another fracture. The quality of life, we've talked a little bit about that. 40% will need assistance with walking. They'll never be independent on their own. They'll need a walker, or they'll need some type of cane or crutch, or they'll need a wheelchair. And look at long-term care admission. 18% of these patients enter long-term care, never to live independently again. And 23%, as I mentioned, will die within 1 year. That's in women. If I was talking about men, then in fact, I would be talking about the startling rate of 37%. 37%. And obviously you don't die from the hip fracture itself, but you die from the complications of the hip fracture. So whether it's an infection, whether or not it's pneumonia, all of these things are so critical for you to take into account. And the lifetime risk of a hip fracture in women more than 50 years is greater than 1 in 10. It's 12.1%. And of that 12.1%, if you have that fracture, again, almost 1 in 4 will die within that first year. Let those numbers sink in for a minute because they really are quite startling in terms of what this means to you. And of course, the lower self-esteem. As many of us lose our independence, we don't necessarily want to go out. We lose our socialization, and we know that social connectedness is such an important factor for maintaining good health. So let's think about people who have a heart attack, both men and women. If you have a heart attack, regardless of gender, about 80% of people who are in the hospital with a cardiac event leave with medication. They get diagnosed as having coronary artery disease. They get treated with a number of medications. There are a whole host of medication, whether it's cholesterol medication or blood pressure medication, about 80%. But let's look at what happens to osteoporotic fractures. In fact, only 15% of patients are treated for an osteoporotic fracture. I don't mean the fracture gets treated. I mean the underlying disease of what led to the fracture, the why of why the fracture happened, 15%. That means that 85% of individuals are leaving the hospital. And although a history of fracture is the strongest predictor of a new fracture, post-fracture treatment rates remain low, too low. And we really want to shift this paradigm, and part of the reason that we're having this talk is that you are responsible for shifting the paradigm as well. Not only the medical community, but your partnership with your doctor to talk about your bones, to ask about your bones, to review your risk factors. We want to remind ourselves that a fracture is to osteoporosis what a heart attack is to cardiovascular disease, and we certainly would not modify your risk factors if you had a cardiac event. Not only do we want to prevent that first fracture, but if you have a fracture, we certainly want to make sure that you're diagnosed and treated to prevent future recurrences. Now, what about Osteoporosis Canada and its guidelines and something called the Fracture Liaison Service? Well, I'm proud to say that Osteoporosis Canada worldwide, and I do mean this worldwide, is looked upon as one of the preeminent organizations in terms of their guidelines, both for diagnosis and management of osteoporosis in Canada. Leaders in bone health across the world turn to our Canadian guidelines because they are so well written. Now it's left to us to make sure that we uptake these guidelines and put them into action. So what's new? Well, we used to focus a lot on bone mineral densities and the score of a low bone mineral density. But now what we want to do is look at you holistically, understand that the bone mineral density is just one aspect of assessing a patient. We want to prevent that first fracture. That's really the gold standard here. And we have two different ways of assessing your fracture risk. One is called CAROC, that stands for the Canadian Association of Radiologists and Osteoporosis Canada, who have partnered together to look at Canadian data and come up with guidelines for fracture assessment. And then there's a tool called FRAX. That's a worldwide tool, but validated by countries, and Canada has its own FRAX tool. We're now recommending higher vitamin D supplementation. While we don't encourage you to get your vitamin D measured as a routine test, if you're Canadian, with our longitude, latitude, our long winters, regardless of which province you live in, chances are that you don't have enough vitamin D on board. We've lowered our daily calcium supplementation recommendation. We want to make sure that you're getting your calcium from your diet. That's critical. And we now have new updated drug treatment options. So there's a host of options to treat individuals who are at risk. So those are the tools that I talked about. The one that's called FRAX is the one that's got the little Canadian flag on it because we use the assessment tool that's validated for Canada alone. CAROC is that 2010 Osteoporosis Canada Association in conjunction with the Canadian Association of Radiologists, and both tools are what we call validated, meaning that they have good data and they make good sense, they've got good predictive value, and it calculates the risk for patients that are not on drug therapy. If you're on drug therapy, that shifts you to a different category, and it cannot necessarily be used to monitor response. But your doctors have these tools available to them, because when we get a bone mineral density score, it's not enough to be able to predict if you're at risk for fracture. We've got to take into account a lot of other factors, like your gender, like your age, and all the other questions that we've talked to you about. So what do we look at? Well, we do look at a bone mineral density, but that interpretation has to be looked at, as I mentioned, by age, by gender, but certainly your fracture history tells us a lot about you already, and whether you're on that medication that I mentioned earlier, the glucocorticoid use, those are all important for us to be able to interpret the data. Now, this is what the CAROC chart looks like for women. There's one that looks at men as well. It looks a little bit different, but has the same green, yellow, and red. And what does it tell us? Well, on one axis, there is the measurement of your femoral neck. Now, that means actually the part of your femur, not your neck on your head, the neck of your femur, so it's part of your hip bone that we're measuring and getting a bone density score. And then on the bottom axis, you can see there's age. And the interpretation of one number is going to be modified by your age. And you can see the green zone, which tells us you're low risk for fracture. We're not concerned about you. The high risk zone, we're very concerned about you, and we are strongly going to recommend medication. And then the big majority of patients fall within that moderate risk category, meaning the likelihood of having a fracture in the next decade is somewhere between 10 and 20%. And for many of these patients, we're going to want to go ahead and do more than just lifestyle counseling. We may want to think about medication for these patients. When we have the DEXA, or bone mineral density, of minus 2.5, it means that for sure you're at moderate risk for fracture. You may be greater. But then there are things that will bump you up a category. So even if you're moderate risk, if you've had that fracture after age 40, that now multiplies your risk, and now you're high risk and you require treatment. Or if your patient is moderate risk and you're on this prolonged steroid therapy, that too will bump you up a category. Certainly, if you've had a prior hip fracture, regardless of what your bone mineral density looks like, you are high risk. And if you've had a vertebral fracture, that too means you're high risk. And if you remove the hip and the vertebrae, look at other fractures outside those two domains. So let's say a wrist and an ankle, for example, that too, having more than one, would put you at high risk. These are all the things that we look at. Now, if you do come up at high risk, without a doubt, that means you're going to need to be medicated. It means your risk of fracture is more than 20% over the next 10 years, or you've either had that prior fragility fracture, or you've had a hip fracture, or a spine fracture, or more than one fragility fracture. We know that you're going to require medication. And there's a lot of good evidence behind the kinds of medication that we use and how the risk of treatment is far outweighed by the risk of not treating. Remember, I told you the lifetime risk of a woman for hip fracture is 12.1%, and mortality is 23% in that first year. Now, we want to address the fact that there is that post-fracture osteoporosis care gap. Remember that slide that I showed you that only 15% of individuals get treated when they have a fracture? Well, that 85% that doesn't get diagnosed or treated, that's the post-fracture osteoporosis care gap. That group is not being diagnosed and treated. So for example, if you've had a fragility fracture, we know that you're at substantive increased risk of suffering another fracture and subsequent fractures. Remember, the 40% of individuals who had the hip fracture had a fracture before that. We don't want that to be you. Half of all patients who suffer a hip fracture, well, they've previously broken that other bone. We call that the signal fracture. It means that you've had a fracture that tells us there's something wrong, and it's really important that we recognize that signal. And for the vast majority, osteoporosis is not diagnosed when that signal fracture happens at all. In fact, we know that 80% who fracture are not assessed, nor are they treated, and all that translates to the post-fracture osteoporosis care gap. We want to close that. So that brings me to talking about a very important service that you need to know about, and that's called the Fracture Liaison Service. What does it do? Well, if you know about it and you need it, it's going to improve the quality of life. It's going to reduce the incidence of avoidable future fractures, certainly save money, which is an important goal. So I call these three goals the I goals. So what do they mean? I for identification. Everybody over the age of 50 who's got a fragility fracture, you've got to look at the risk factors for osteoporosis and future fractures. You've got to address them and assess them. The I for investigation. So in other words, if you are at risk, you've got to have appropriate investigation. So if we identify you as being at high risk, we have to talk about whether or not you need a bone mineral density, whether you've had a bone mineral density, when you should repeat it. And the third I is initiation, and that means where appropriate, patients should undergo treatment opportunities and discuss treatment options for them. So the three I's of identification, investigation, and initiation of therapy. The goal of the Fracture Liaison Service is to improve that quality of life, to reduce the incidence of avoidable and often life-threatening fractures, certainly to talk about and reduce the disruption to patient flow in the healthcare system. And how we can do that? Well, we can do that by decreasing pressure on an already scarce orthopedic resources. We know how scarce those resources are. To free up the capacity for elective surgery, because it becomes urgent surgery if you have a hip fracture, and decrease the pressure on long-term care beds and demand for home care with our aging population. All this leads to significant cost savings, but more importantly to you as an individual, it really speaks to the quality of your life, the ability to be independent and have a fracture-free life well into your ongoing years. How do we eliminate the care gap? Well, some medications have been available for 20 years, but 80% of people who fracture actually don't get treatment at all. And we really want to signal the fact the signal fracture, that signal fracture is so important to pay attention to because it really does give you the signal that you need to be prescribed a medication. Because we know that treatment can reduce not all future fractures, but at least by 50%. And we're really committed at Osteoporosis Canada to work with all the key stakeholders in Canada to eliminate this unnecessary care gap. So we know if you know about the Liaison Fracture Service, and you can spread the word as well, go to our website, learn about it. We know that it will significantly reduce the incidence of repeat fractures and certainly can help create and support the infrastructure to really deliver that post-fracture care. So what are the faces of osteoporosis? Well, let's look at our first patient, Cheryl. She's 65 years old, she's postmenopausal, and she's newly diagnosed with osteoporosis. And if we look at her lifestyle, it speaks to some of the risk factors that she has, and she may not be aware that in fact these are risk factors. Drinking 5 to 6 cups of coffee a day, not a very bone-friendly item, caffeine, 2 to 3 glasses of wine in the evening. She exercises when she can fit it in, and the when she can fit it in may not be all that often. She takes a multivitamin, but only when she remembers. Does she sound familiar to you? Well, let's look at our second patient, Esther. She's 75 years, she's postmenopausal, but you know what? She's been living with osteoporosis for 8 years. She takes her calcium in an appropriate dose that supplements her diet to bring her up to the 1,200 milligrams we recommend. She takes a vitamin D supplement, and she quit smoking as soon as she was diagnosed, which is one of the most important things she could have done, not only for her bones, but her heart, the risk of cancer, and every other aspect of her life. Look at Diana. She's 58, she's postmenopausal, and she's living with osteoporosis, but didn't really know it originally. She fractured her wrist when she was 48 years old, but that signal fracture did cause her to have some investigations, and in fact, she does take osteoporosis medication, even though she's 58 years old, and many of us think of osteoporosis as a disease of older men and women, and she exercises on a regular basis. She puts it into her calendar, she makes an appointment, and she treats it as an appointment that she must keep. So what are our treatment options? Well, women with a wrist fracture have double the risk of any future osteoporotic fracture. And I start with that because wrist fractures, they're pretty common, but it really speaks to the importance of preventing that next fracture. If you've had a vertebral fracture, and you know what, 2/3 of people who have vertebral fractures don't even have pain. They don't even know that they have a fracture. They may think that they're a little bit shorter, but that can predict future risk of a hip fracture. And only 44% of people discharged from hospital for hip fracture actually ever make it back to their home to independent living. And I've got older parents, and the most important thing to them is independent living and making sure that they can be in their own home with self-care. Of the rest, about 10% go to another hospital, 27% will go to rehabilitation care, and 17% tragically will end up with long-term care facilities. And that really is a concern. Just think for a moment how you want to live your so-called golden years. And look, we've got patients as early as 58 who had fractures at 48 that are impacting on prediction about their quality of life as they go forward. Vertebral fractures. Well, 2/3 of them, I told you, are pain-free, but in the other group, they can cause really severe disabling back pain. You know that hump that some women have at the back of their neck, often called a dowager's hump? That is because of osteoporosis and fractures. And it increases the likelihood of death within 5 years 4 times. Now we're talking about a vertebral fracture. And it may not be obviously the vertebral fracture itself that you die from, but again, it's a marker of frailty, and we know that it associates to that increased risk of death. Therapy? Well, therapy could reduce all of this from happening. So what are the treatment options? Well, there's lots of common treatments that you may have heard of, and there are many different types of osteoporosis medications. They work a little bit differently in the body, and I'm actually going to go through and tell you where they work. Well, for all of us, lifestyle is critical, so calcium and vitamin D, we're all going to put that on our to-do list. There's a group of medications called bisphosphonates. There's another group of medications called selective estrogen receptor modulators, and no, they're not estrogen, even though they have the word estrogen in them. They're often abbreviated as SERMs. Then there are hormones themselves, and there are bone formation agents. And there are some newer treatments that are available now, one called a rank ligand inhibitor. And I know this all sounds complicated, but we're going to go forward and learn a little bit more about each of these treatments. And really, it's a conversation between you and your doctor to understand how the medications work, where they work, how you can take them. That really will help you decide what you need to be doing. You know, we think about medications as only being oral and tablets and pills, but in fact, there are different ways that you can get osteoporotic medications into you. One is by an annual intravenous infusion, and one is by shots, subcutaneous shots that happen on a daily basis. That means just under the skin, or a subcutaneous shot that happens only twice a year. Many people we know will stop taking their treatment either because of side effects or because they have challenges with the medication schedule, or they don't take it exactly as prescribed. Some of these medications need to be taken first thing in the morning on a completely empty stomach with a glass of water, and you have to wait an hour till you can lie down again. And we know that some people only take the medication half of the time. Well, that's almost as good as not taking them at all. So you really have to think about not only initiating treatment, if treatment is indicated for you, but what is going to help you persist with the medication, to take it on a regular basis. Now here's a really complex looking slide, but I'm going to remind you back to the beginning when we talked about those bone builders. Remember the osteoblasts? They're building the bone, and the osteoclasts, there are digger Dans, if you will, who are excavating so that the osteoblast can lay down bones. Well, the way the osteoblasts and osteoclasts work is they talk to each other. In other words, the osteoclast can't get revving and turn on its motor and excavate to build a space for new bones unless the osteoblast tells it to do that. And it does that in a very elegant way of talking to each other. The osteoblast puts something out, these little green guys that you see in our picture here, well, they're called rank ligand. Think of them as a key. And they bind to something called rank on the osteoclast. Think of that as the keyhole. So you need the key to go into the keyhole so that the osteoclast can start its motor, get revved up, and start excavating. Now, if you understand this, which is quite complicated, you can understand where medications work. There's a medication called teriparatide, and that actually builds new bone by talking to the osteoblasts. Denosumab, which is our subcutaneous injection every 6 months, that works by speaking to the osteoblast to sort of mop up those little green guys so not as many of the osteoclasts get busy excavating bone. Our group of medications called bisphosphonate, well, they slow down the osteoclasts and tell them not to excavate so much. So it sounds pretty complicated, and it is pretty complicated, but we now understand where these medications work, how they work, and how they can improve your bones. And it's important to recognize that there are many treatment options. And then when we talk about estrogen therapy in newly perimenopausal women, or the selective estrogen receptor modulator, they also work on the bone builders to make a difference in how bone is built. So that's really complex, but now you know a lot about bone biology, and while you may not remember all of it, and it's really not critical that you do, it's important to understand that these bones work through the medication targeting specific cells to help reduce your risk of either that initial fracture or future fractures. Okay, so what's out there? Well, you can see on this very complicated slide that, in fact, there are a lot of first-line treatment recommendations. And what first-line treatment recommendations mean that all of these treatment options work well at a variety of sites, and it really is a conversation between you and your doctor to decide which medication is good for you, whether it's the group of bisphosphonate or denosumab or a medication called raloxifene, or if you have an indication for estrogen hormone therapy, or where it's teriparatide. It really is a conversation. And this is an option that you can visit on Osteoporosis Canada to take a look at this in more detail. So what about the medications? Well, you can see that in our group of medication called bisphosphonate, well, you can see some names that you might recommend. Zoledronic acid is something called Aclasta. Risedronate is a medication called Actonel. Didracal is used in some parts of the country, not other parts of the country. Alendronate is often called Fosamax or Fosavance, and these all work by, remember the osteoclasts? Well, they bind to the surface of the bone and they slow down the osteoclasts, so therefore they slow down bone breakdown. And how it's given depends on the specific medication. Again, that's a conversation that you can have with your physician, whether it's an IV infusion or whether it's once a week or once a month. The most common side effects as a class of medication usually looks at things like stomach upset, a little bit of heartburn. Some people have described flu-like illnesses or musculoskeletal pain, very rarely fever or skin reactions. And there are a host of other reactions that we can see that are really not all that common. And again, you can visit our site to take a look at this in more detail. The other medication that we've looked at, SERMs, those selective estrogen receptive modulators, and hormone therapy, and I've listed a few of the hormone therapies that are available in Canada, they increase either the hormone level to prevent bone loss, or they act like a hormone to help build and maintain bone density. And typically they're either daily, or in the case of hormone therapy, they can be a daily patch, they can be a transdermal gel. Again, it really depends. And the possible side effects will depend on the specific medication. Again, a conversation for you to be having with your physician, but both of these work well. Then our other agents are bone-forming agents. That medication, teriparatide, is marketed under the name Forteo, and it actually builds bone cells to form more bones, and that's a daily shot given under the skin for up to 24 months. That rank ligand inhibitor that I talked to you about, denosumab, is marketed under the name Prolia, and it works in the body to stop those cells that break down bones so the osteoclasts never get turned on. And that too is an injection just under the skin, but it's given once every 6 months, twice a year, by your doctor. And the possible side effects are listed for you to review. Okay, how are you going to have healthy bones for life? This is a really important message that you need not only for yourself, but up the generation and down the generation. Firstly, it's really important to participate in regular weight-bearing and strength training exercise. But what you do depends on whether or not you have osteoporosis or you don't have osteoporosis. So certainly if you are an individual at risk or have osteoporosis, we don't want you working with heavy weights. But for the rest of us, running, brisk walking, dancing, working with those free weights, swimming, almost any exercise that weight bears is really important. Strength training, really important. And we want to make sure you get enough of that calcium and vitamin D. So the 1,200 milligrams that we often talk about, ideally that's from food. And you need to sit down and figure out how much calcium am I getting from food? How much do I need to add as a supplement? What about vitamin D? Well, somewhere between 800 international units to 2,000 international units of vitamin D every day, year-round. Really important to be consistent with it. And make your diet count with sufficient calcium and protein. So it's important to follow Canada's food guide, to eat low-fat dairy. It's a great source of calcium and vitamin D. And for those of you who feel that you're lactose intolerant, there's lots of lactose-free great sources of calcium. And in addition, there are non-dairy foods that offer you calcium as well. And we've got a list of all of those foods and the quantity of calcium that you see in each of those foods on our website. And I think it's really important to actually take the time and become familiar with what is your diet and what you're getting in your diet, and to really make sure that your diet counts. Remember, fruits and vegetables, all those colorful fruits and vegetables, really important because they may not have calcium or vitamin D, but they've got lots of other nutrients that are important for your bones and really important as baselines for bone building nutrients. There's alcohol again. Really important to remember to limit your alcohol to 2 or fewer drinks per day. Too much alcohol is very bone unfriendly and increases your risk for fall. We don't want you smoking, and if you're smoking, please get some help to quit. And ask your doctor if any other medications that you may take can be unfriendly to your bones. We've mentioned glucocorticoids, those cortisones, those steroids, but there's a whole host of other medications that you may be required to be on but are bone unfriendly. And it's a really good idea to have that conversation with your physician so you can understand about your risks. We want you to take measures to prevent fall. Fall is a major risk for fracture. So you want to take a look around your house, make sure that you don't have rugs that you can trip on, that you aren't wearing those high heels, or you aren't climbing up ladders. Things that you can do, bars in your bathroom or bars in your shower, measures that you can take to prevent falls. And everybody over the age of 50 should have a fracture risk assessment. Now, that doesn't necessarily mean a bone mineral density. That may mean just a questionnaire to look at your height, look at your weight, all of those other things that we talked about. Add balance and posture training to your exercise program. They're both important. We know that if you have a strong core and a strong posture, it will really help to prevent you from falling. One of the best exercises that you can do is something like Tai Chi. Speak to your doctor about treatment options that are right for you. So if there are medications that are out there, there's lots of headline news that often has people fearful of taking medication, but you really need to get the facts and the evidence from your doctor about what is right for you. And you know what? You can become a member of an osteoporosis support group because we know that there's strength in numbers, there's support from other individuals in the same situation, and I think it's really a wonderful thing to do. So where can you get more information? Well, we hope you've gotten a lot of information from us today, but you can keep up to date with the latest osteoporosis information by going to our website. So the website is www.osteoporosis.ca. Not everybody loves computers and not everybody is web friendly, and that's why we've got an information line as well. And our information line is 1-800-463-6842. And we're there Monday to Friday from 9 to 5 Eastern Standard Time. Believe it or not, if you call, there's a voice on the other end of the line. You can follow us for those of you who like social media, because we do have a Twitter account, we do have a Facebook account, and you can follow us on all of these sites. You also can become a member of the Canadian Osteoporosis Patient Network, and that's part of a nationwide network of support all across this great country. What does the network do? Well, it connects individuals that are affected by osteoporosis. It communicates information about how to live well with the disease. It advocates for comprehensive access to diagnosis, treatment, and care. And yes, membership is free. Because we started this evening by telling you the most important aspect that we can offer you is education. You can only be empowered by understanding how important it is to know about osteoporosis and your risk for fracture, because this truly can be a life-threatening disease or a life-changing disease. So there's lots of information that we've looked at. There's lots more information as well. And we've left time to take your questions so that hopefully something that hasn't been covered or requires further explanation is something that we can do with you now.
Thank you very much, Dr. Shapiro, for that wonderful presentation. I know sometimes the information on particularly the treatment options can be very complicated.
Really complicated.
I think you've done a fabulous job of distilling it down.
And we do want people to know that they can go back to the website, and this is not meant to tell you everything possibly that's out there, but really to be a primer for you, a building block, if you will, to be able to go forward and get more information. So don't feel overwhelmed or sort of, oh my goodness, what does this all mean to me? It means that there's a lot of options out there, and the conversation, the dialogue is one that has to keep on going.
Absolutely, absolutely. So one of the wonderful things about a webinar is that we are able to address your questions in real time. Some of you have already submitted questions. You will notice there's an Ask a Question button on your screen. If you wish to submit a question, please do. We can't guarantee that we will get to all of them. We have probably about 10 or 15 minutes to address some questions. So let's get started.
Let's try.
So a question from Mary. If you prevent reabsorption with bisphosphonates, are you not left with old bone?
So this is a very good question that people ask, that you're preventing the resorption. What we're trying to do is get things back in equilibrium. So often what happens in osteoporosis is that the resorption outpaces everything else. So we're left with bones that are more porous and more at risk for fracture. And we know that women are particularly at risk because estrogen, as you saw in one of the slides, is very important for speaking to the osteoblasts to release the rank ligand to bind to the rank on the osteoclast so that they're in balance. And when we lose our estrogen, it goes out of balance. All that rank ligand pours out. Too many of those osteoclasts get activated and too much of the bone gets resorbed. So we really want to keep things in balance, and that's what these medications that are classed as anti-resorptives do. They try to put things back in balance so that you don't have the accelerated resorption. So think about, the fact that you're building a whole community of houses, and you want to build a house, lay a foundation, build a house, lay the foundation, but you've got to have the digger Dan, if you will, excavate. Imagine if you've got all this excavation, but nothing laying down the cement, mortar, and bricks. You're going to outpace the ability to lay down those foundations. So that's what we're trying to do. We're trying to get things back in balance.
Yes, great question. And a question from Cheryl. How low can your bone density number be?
Oh, well, it can be very low, and that's what we want to prevent. So when we talk about assessing bones, and this is where people, I think, Dr. Jiwa, get very confused about the bone mineral density. We have a lot of healthy young women in around 50 saying, I want a bone mineral density, who really don't need it. When we talk about assessing your risk for fracture, the first thing we do is good old-fashioned medicine, which means we do a history and we do a physical. So we're going to ask you important questions like, have you suffered any type of fracture since the age of 40? what is your diet and lifestyle like? So how much do you smoke? What's your alcohol intake like? And remember, when you're seeing someone like me, we're not your parents or your mother, so you got to be honest, because we can't give you good advice unless you're honest with us. We'll do a height, we'll do a weight, we'll ask you to do something called a get up and go test. That means getting up from a chair like I'm sitting on without any arms. Can you get up and go? And that tells us a little bit about your risk for fall. There's a lot of things that we can do. We'll ask you to stand straight with your back against a wall and see whether or not you've got that dowager's hump that's keeping you from being erect against a wall. We'll look at your weight compared to what it was at age 25. And we'll look at what your medications are. Are there any other medications that make us think that you might be at accelerated risk? We'll look at, for example, inflammatory disease such as rheumatoid arthritis or certain inflammatory bowel disease. We know they have a link with accelerated bone loss. So we're really going to do a history and a physical first and decide up until age 65. If you don't have any major risk factors, for example, a parent who's had a hip fracture, then we'll likely not do a bone mineral density. After age 65, everybody, and that means the men, remember 1 in 3 women, 1 in 5 men, everybody should get that bone mineral density as a baseline. From that bone mineral density, we'll be able to get that CAROC score, whether you're low risk, moderate risk, high risk, and that will help us have a discussion. So yes, we do see people with severe osteoporosis that, can be even -3, -4, and those are patients that truly have not been diagnosed early enough, and we want to change that. So we're now focusing with the new guidelines, instead of just looking at the bone mineral density score, we're really focusing on that overall global assessment. How do we assess your risk for fracture? And yes, the bone mineral density is a valuable tool, but it's not the only tool.
And speaking of not being diagnosed, that's a great segue into this question from Sarah, who asks, can you tell us more about the Fracture Liaison services?
So, the Fracture Liaison service is really a way, I think, of empowering people. Because often, as we showed you at the beginning, that only 15% of people who have a fracture ever get asked the question, why did you have the fracture? So you come in with a fracture, and yes, you'll get casted or you'll get treated appropriately. We don't mean to say that orthopedics isn't doing a good job, but often the question that needs to be asked is, why did you have that fracture? Is there something about the quality of your bones, the density of your bones, something about your lifestyle that's put you at risk? So the Fracture Liaison service, if you've had a fracture after the age of 40, and you haven't been appropriately, or maybe let's take out the word appropriately, you haven't been investigated or necessarily been asked the questions or had a really good investigation either historically, physically, or the discussion about a bone mineral density, it allows you to reach out to the Fracture Liaison service. You yourself, as a patient, can reach out to them and get information about what is it that I should be doing. And the attempt here is that often orthopedics, as we know, is overwhelmed with the volume of fractures that they see, and it's difficult enough to keep pace with, treating the actual fracture. So we need to build an infrastructure to help support our colleagues, whether it's through primary care, other subspecialists who are interested in bone, and there's a whole bunch of us who are interested in bone. But now I think it's a way of saying to the Canadian public, you get involved too. You get educated, you get informed, reach out to Osteoporosis Canada, and if you have a question, you can get involved in the Fracture Liaison service.
Absolutely, and certainly, if I may, at Osteoporosis Canada, that is certainly our area of focus. In certain parts of the country, for example, in Ontario, we have a very robust funded Fracture Liaison service program, which captures patients as they come through the emergency room and screens them for osteoporosis to prevent that second fracture. We are committed at the organization of implementing this program across the country, so stay tuned, and we will certainly welcome your input and participation in this movement.
Yeah, so the goal here really is to have a Fracture Liaison service throughout the country so that it takes the burden off orthopedics, for example, but highlights you, flags you, if you will. I've had a fracture, and the liaison service will liaise with you, between the patient and what other services. But patients themselves can certainly reach out to Osteoporosis Canada and get that information. So while our goal is 100% Fracture Liaison across the country, it takes a while to roll out these programs everywhere.
Absolutely. And now on to a question about medication. A question from Lucille. What can you tell me about Prolia? What are the advantages and disadvantages?
Okay, so let's first go back a bit. Prolia, that's the market name. The chemical name is denosumab. So this is an injection that's given under the skin once every 6 months. Now, if you can remember back to that slide that I showed you that looked at those green guys, so those little green guys are what we call rank ligand. They are the ones that I told you to think of as being a key. They're necessary to go into rank, which is the keyhole in the osteoclast to activate the osteoclast. The idea is that in the postmenopausal state, we know that we lose the regulation and we get way too much of this pouring out, too many osteoclasts eating up bone. So Prolia works by an injection to mop up all this extra keys, if you will, so that the osteoclasts do not get turned on. That's how it works. The medication is a well-tolerated medication. Certainly we've had many years of experience with the medication and we've had many studies of the medication. In some areas we've seen in patients who are at risk an increase in skin infections, easily treated, easily identified. Some patients, it's very important to make sure they're getting adequate calcium, as it is with all these medications, to make sure they're getting adequate calcium. But we haven't seen any signaling in terms of things like tumor or cancers, or people always worry about, is this going to increase my risk for other diseases? So in fact, for the most part, it's a very well-tolerated disease. And again, when it comes to any medication, it's really important that you have that one-on-one conversation with your physician to see what's best. One of the pluses of this medication is that it's an injection given every 6 months, because we know that patients initiate medication, but it's so hard to adhere and take it properly all the time. So for many patients who don't want to be taking yet one more medication or have trouble with a medication in terms of the way it's taken, this is a different route of administration. So that, I think, is what's newest in terms of the medication, that now we have a different route of administration. We have lots of efficacious medications. They are anti-resorptives, that class of anti-resorptives. The bisphosphonates fit in there as well, and those are medications that typically are oral, different types of side effects. So again, really important to have the conversation. We know that this medication works at the 3 sites that we worry about. It works at the level of the hip, the level of the vertebrae, and the non-vertebrae in terms of reducing the risk for fractures.
Great, thank you. And now on to a question from Liz. Why are more women at risk of osteoporosis than men?
That's a great question. It really is a great question. A lot of it has to do with the fact about estrogen. That estrogen is very important for speaking to the osteoblasts when pouring out that information that turns the osteoclasts on. And when we lose our estrogen, we lose the regulation of that relationship between these two different bone builders and bone cleaner-uppers. So women at osteoporosis, or women at perimenopause, so the period of time leading up to menopause and early menopause, get accelerated loss of bone with a loss of estrogen. So that's why women are typically 1 in 3 and men worldwide 1 in 5. And I also want to remind women that often we don't necessarily build our maximum bone strength during our growing years. So adolescence into early adulthood is when it's so important to make sure you're getting your adequate calcium and vitamin D, because if you don't build up your bone mass and you're at a deficit to begin with, then you're going to be even that much more at risk as you go through life.
Absolutely, it's a critical piece of information.
Critical piece, which is why we often say that osteoporosis presents in later years, but really it's a pediatric disease. So we want you to make sure that your kids are getting adequate calcium and vitamin D. So it's a message that plays down the generations and up the generations.
Exactly.
Yeah.
Which is also another good segue into this question from one of our viewers.
I feel like I've got ESP.
At what age should I start taking calcium to help protect my bones?
Calcium is lifelong. Lifelong. So from the get-go, we need to make sure that we're getting adequate calcium and vitamin D from the day our children are born. What do we give breastfed babies? We give them a vitamin D supplement because it's a large molecule that doesn't get excreted in breast milk. So it's important that all of us get adequate calcium and vitamin D. So it's from 0 onwards. It never stops. It's really important, and it's important to understand that there are some age-related differences in terms of the amount of calcium, but again, we want you to get the calcium from your diet. So 4 dairy servings a day, that will do it. Make sure you're taking a vitamin D supplement, because usually we're not getting enough vitamin D from the sunshine, and we don't necessarily, basal cell carcinoma is our #1 skin cancer, so we all welcome the sun in the summer months, but we need to use our sunscreen. So it's important to recognize where you need a supplement and where you don't need a supplement, but really try and get the calcium from your diet from day 1. It never stops.
Yes, absolutely. Well, we have time for 2 more questions. How much does strength and resistance training help somebody with osteoporosis?
So strength and resistance training, we would like you to do it lifelong to prevent that diagnosis. But certainly it's never too late to do exercise. It's never too late to do strength and resistance. But if you have osteoporosis, obviously you're more at an increased risk for fracture. So we want you to be cautious about the type of exercises that you're doing. So heavy weight bearing or sudden twisting or bending, that may not be the best thing for you. And we know that exercises that build up your core strength and stabilize your muscles, they're going to prevent you from falling, and that is critical. So the type of exercise you do may be dependent on your ability, on your underlying diagnoses, but there certainly are exercises that can be done by everybody, the specifics of which are really going to depend on you as an individual and what your underlying situation is.
Great. And our last question, again, is related to medication. Should you stay on Fosamax for more than 5 years?
So this is a specific question that's difficult to answer without, the evidence in terms of what is this particular patient. High-risk patients, we typically will medicate. We're now beginning to think about the concept of sequential medications, being on one medication for a period of time and then going on to another medication. So for example, if you're high risk for blood pressure, we don't treat you for 5 years and then stop. It's a chronic disease. So high risk is high risk and requires some type of impact and treatment. And I think the reason that we're being asked this question is that a lot of people hear about the term drug holiday, meaning I should take a holiday from your medication. And in some cases that's reasonable. In other cases it's not reasonable. So I can't answer this question specifically other than to tell you that this is a question that you need to ask your doctor, because you know what I see, Dr. Jiwa? I see people stopping medication on their own without having the consultation with their physician to know whether or not it's the right thing for them to do. And then, they'll come back 18 months later and I don't know that they haven't been taking their medication and there's a sudden loss in their bone. So you need to have trust and a relationship with your healthcare provider to have the conversation about what should I be doing, not what my neighbor is doing or not with my friend across the street, because your specific medical history, the other medications you're on, your family history, all of those things are so specific that there can't be one general answer, which is why this is great to get the education, but it's meant to empower you to move it forward and have this conversation with your physician and make sure that you make it a priority if you have a level of concern.
Wonderful, wonderful. Thank you.
Thank you.
So we are almost out of time. I do want to take a moment to thank you, Dr. Shapiro, for taking the time.
Thank you for inviting me.
You've always been a wonderful supporter of Osteoporosis Canada, and we're honored to have you as part of our family. So very, very happy to have you do this presentation. I hope you've all enjoyed the presentation. As Dr. Shapiro has referenced throughout the presentation, we have a great deal of information on www.osteoporosis.ca. Many of the questions all of you have sent in that we have not unfortunately had time to get to are answered within some of our already existing material on our website. If you don't find it there, feel free to contact us using the tab on the website, and we'd be happy to get back to you. Also, this webinar will be referenced on our website and archived should you wish to view it in the future, or perhaps some of your family members or friends want to come back and look at this. So once again, thank you for joining us. I would urge you to visit our website, where we have a great deal of information in addition to a monthly newsletter that comes out full of great bone healthy information. So thank you and have a good evening.